Hello, and welcome to another session of digital slide review and surgical pathology sign out. I'm Dr. Louis Hassel, coming to you from the University of Oklahoma Health Sciences Center, where I'm professor of pathology. And our program is part of the Digital Anatomic Pathology Academy, a joint venture with Path Presenter and the Digital Pathology Association, which helps to sponsor this program. Not, however, through any financial remuneration for me, however. Our case today comes from the realm of GYN pathology and illustrates a challenging dilemma sometimes in surgical pathology, which I thought would be good to discuss. The dilemma is what to do with mucin within the ovarian stroma. So the dilemma is this an invasive mucin-rich cancer, or just an extravasated pool of mucin from a ruptured benign mucinous gland? The patient in question was in her early 60s and had an ovarian mass that came to frozen section evaluation and largely contained mucinous fluid, but had one area of more concern with areas of high-grade cytology and areas where mucin was present in the stroma. Here's a representative section from that area. And as you can see, there's variable size mucinous cysts. You can see some degree of mucinous proliferation here along the surface, the epithelial cell proliferation going on here. And if we come in at higher magnification, you can even see that this has reasonably high-grade cytology and would qualify probably as intraepithelial carcinoma. We have some preservation of goblet cells in this enteric phenotype tumor, but by and large, the nuclei are large, hyperchromatic, and somewhat concerning. Additionally, the mucin here contains exfoliated cells, some inflammatory debris, and so forth. Nearby, we have these areas where within the stroma, as you see here, there is loose cellular loose cellular material, mucinous material, and some admixed inflammatory cells. So we'll look at a few more of these to get an idea of what this process is. And the dilemma here, obviously, both at frozen section and on permanent sections, is this invasive carcinoma? Or are these simply extravasated areas of mucin and we have perhaps only intraepithelial carcinoma? So here's another area where you can see we have a very inflammatory type response with numerous histiocytes and some multinucleate giant cells, or possibly you might even think about tumor cells in some of these areas. And these are in between the otherwise cystic glands containing lined by mucinous type epithelium with high-grade cytology. So are these mucin granulomas from ruptured glands, or is this evidence of an invasive mucinous carcinoma with so-called pseudomyxoma ovarii resulting in these inflammatory pools? Here again, you see one of these giant cells admixed here and additional giant cells here. Well, we examined this case very, very carefully. And on rare occasions, we found a fragment of epithelium floating within this mucinous material. But by and large, the process was extremely limited in that regard and consisted predominantly of this mucin within the stroma with a giant cell type response, what has been termed a mucin granuloma. So I thought this would be a good discussion of whether or not, or what the characteristics are that distinguish mucin granulomas from mucinous carcinoma. And here's another area of this. You can see a pool of mucin, rather, inflammatory type process, admixed histiocytes in here, fragmentation or spindling of the stromal cells around it, and then adjacent cystic structures with this extravasated nuclear debris consistent with the intraepithelial type carcinoma that we had identified previously. And of course, these digital slides are available for you to study afterwards, and I will provide the link in the video details. Here again, we see this very inflammatory type process, a lot of histiocytes. And you might on occasion wonder, are these histiocytes, are they some of these neoplastic cells? They do have some nuclear enlargement, and you might look at cells like some of these and say, well, these are probably carcinoma cells. And of course, if that's your concern, you can do immunohistochemical markers looking for cytokeratins or EMA and so forth. However, some warning, and that is that sometimes histiocytes can take up cytokeratins if they have engulfed epithelial cells. But I think concomitant CD68 would affirm that these cells are histiocytes rather than epithelial cells. So let's go on and look at a contrasting case, which also has pools of mucin within this, but thinking first of kind of the sources. I mean, obviously, primary mucinous neoplasms within the ovary can rupture both benign as well as borderline lesions and malignant lesions to produce stromal mucin. Endometrioid neoplasms sometimes can have mucinous differentiation, although they less frequently cause these extravasated pools of mucin. A teratoma with a prominent mucinous cystic component could also produce gland rupture and potential mucinous granulomas or a pseudomyxoma type of appearance. And metastatic mucinous tumors quite typically can produce this. Primary peritoneal mucinosis, maybe pseudomyxoma without an identified source, might also cause ovarian mucin, but that would be decidedly rare. So let's look at some of the other causes for this. And here's an example. Again, we can see at low magnification, we have pools of mucin associated with this. And some of these cystic structures have obvious epithelial linings. And so we'll look at this mucin a little bit more carefully to determine what's similar and what's different to what we've just looked at. Well, one of the things that I think jumps out at us right away is how clean this mucin is. I mean, as you look at this mucin, you can detect virtually no inflammatory type response. This is mucin that's just kind of sitting and floating here free with very little within the mucin itself. So this mucin is quite impenetrable to inflammatory cells. It's not a watery mucin. Now there is some sort of fibrosis or inflammatory response in the stroma around it. That's typical. And in fact, this stromal response, as we look at this, in fact, you'll note how collagenous this is. And this is a clue. This is a clue that you should not miss. In fact, that this is a low-grade appendiceal mucinous neoplasm, which very characteristically produces a dense hyaline type fibrosis on which this very low-grade epithelium will rest with virtually no lamina propria type of change. So that's another feature here. We have this dense collagenous type of stroma and mucin that is really quite impenetrable to inflammatory cells. And here we can look around and see a little bit more. So here where it's just beginning to abut the stroma, we see less of this process, but even here where it's relatively bland, we can see the beginnings of this hyaline type fibrosis within the stroma. And that's more the pattern of metastatic mucinous neoplasm than a primary ovarian neoplasm. Here again, we see this mucin adjacent to large vessels. Again, another feature suggestive of metastasis rather than of primary ovarian mucinous neoplasm. Here again, note again the juxtaposition of the mucinous cystic epithelium here. Very bland, very low appearing, but yet right next to significant sized vessels. And as we look a little further, you can see, some zonation maybe to the mucin, but no cells within this mucin. Very, very few cells of any kind, either epithelial or inflammatory. We go to another example of this process. Here's a contrasting breast biopsy of a mucinous carcinoma. And again, in this situation, note how clean the mucin is. There's really no inflammatory cell reaction here. But here, obviously, we have floating cells, floating nests of tumor cells associated with this neoplasm. So although obviously the breast is a little different than the ovary, sometimes the lessons from the histologic patterns in one location can be instructive for another. And another example here, more obviously an invasive process. But again, note how clean this mucin is in this particular situation. And in fact, in gastrointestinal mucinous neoplasms of this type, whether from the appendix or elsewhere, this is a characteristic feature that is quite typical. A very clean mucin with floating nests of tumor cells within that mucin and virtually no intramucinous inflammatory response, in contrast to what we saw in our incident case. Now, sometimes mucinous carcinomas can have abundant epithelial atypia and relatively little extravasated mucin, but abundant intraluminal mucin. And here's an example from the ovary of a metastatic mucinous carcinoma with abundant intraluminal mucus. But note how closely it mimics the endocervical type of mucinous neoplasm. Entirely basal nuclei, no goblet cells, just very, very low-grade histology in this case. So no extravasated mucin pools in this area, but note the low-grade cytology that can be seen. So if we were to summarize things, I think the way to think about the differentiation of pseudomyxoma from a mucinous granuloma is as follows. We've emphasized how clean the mucin is in pseudomyxoma or in mucinous colloid type lesions. Nests of tumor cells may be seen floating in the tumor mucin. And very frequently, you'll get a very dense collagenous response, especially with appendiceal neoplasms. These will usually have an enteric phenotype. Of course, some primary ovarian tumors can have a primary enteric phenotype, and they will almost always be SATB2 positive, usually a very good marker for enteric origin. In contrast, the extravasation type granuloma of mucin from a primary ovarian tumor usually presents as mucin in between existing cysts, with or without evidence of clear-cut cyst rupture and incomplete glands. There will be a histiocytic response that often includes giant cells if you look hard enough. And there will be virtually no or only very, very rare floating tumor cells that would have been mechanically displaced into the mucin pool. You may have some fibrinoid debris along with the mucin, and the surrounding stroma will also be somewhat inflamed as well. So those features, I think, can help you to differentiate this. Here's just a quick example, and I think we've got a couple of highlighted spots here. Let me go right to them. So here's one right here. And we can see in this is a frozen section slide. And so here we can see a couple of pools of mucin, one with a little bit of epithelial lining and one with a floating nest of tumor cells here. So were you to see this on a frozen section of an ovarian tumor, as was this case, this kind of feature with a very clean mucin and floating nests of tumor cells could be more readily diagnosed as mucinous carcinoma, probably metastatic. In this particular situation, we do have the high-grade histology that we've alluded to earlier. And I think there was one other area here, down here. We'll take a look at this area as well. Again, you see this sort of dissecting pattern of mucin, still fairly clean, and little nests of tumor cells associated with this tumor that provide evidence of a invasive nature of the mucin and the neoplastic cells in this tumor. So again, nice evidence of carcinoma in this circumstance. Another example, here we see mucin, here we see extravasated, or you see pools of mucin. But notice we also see, even at low magnification here, lots of pink stroma, lots of very hyaline material. And here we can see, again, this epithelium, sort of atypical, but very basal nuclei existing right on top of this very hyalinized stroma. And here, pools of mucin, very clean, minimal inflammation, maybe a little hemorrhage, and a lot of this dense hyaline type stroma, again, suggesting very strongly a primary appendiceal neoplasm, low-grade appendiceal mucinous neoplasia, as we call it, lamin, that would be very characteristic with this type of a pattern. And finally, coming back to our incident, well, actually, no, here's one more example. Here we see, again, mucin, but note again here that we see dissection of this mucin into and around large vessels and fatty tissue. Again, evidence of a neoplastic process. And here we can see associated with these mucin pools, irregular, atypical glands, very jagged in terms of process, and both floating epithelial cells and lining epithelial cells. So in this case, the architecture and the geography helps to define this as an invasive mucinous neoplasm rather than the simple extravasated mucin type granulomas. And here again, you can see floating epithelial cells within some of these areas, as well as dissecting epithelial cells outside of the mucin pools that help to define this as an invasive neoplasia. So then to come back to our incident case here again, just to refresh your mind, here again you see the inflammatory, see the fuzzy, busy nature of this mucin pool. So even though you have malignant epithelium nearby, this is a case where the mucin is not indicative of invasive neoplasia, but is just a component of glandular rupture with histiocytic response. And so this case would qualify as a mucinous borderline tumor with fairly extensive intraepithelial neoplasia and extravasated mucin with mucin granulomata, but not invasive carcinoma. Note that this is not typically the pattern of invasive mucinous carcinoma. It has a destructive invasion and a colloid pattern type of invasion, or a mucinous dissecting mucin type of invasion is not characteristic of mucinous ovarian carcinoma as a primary tumor. So with that, we summarize how we signed out this case, a mucinous borderline tumor with an intraepithelial carcinoma and stromal mucin granulomata. That certainly is a much better prognosis for the patient and portends a close follow-up, but not necessarily additional chemotherapy, in contrast to giving her the diagnosis of mucinous adenocarcinoma. Well, we hope that you enjoyed that program and that will be helpful to you as you encounter this dilemma in diagnostic pathology in some of your cases of mucin-related tumors in the ovary and elsewhere. If you like this program, please hit the subscribe and like button. Share it with your friends and colleagues if you can, so that they'll get word of this effort to provide educational enlightenment and instruction without charge. So until next time, thanks so much for joining me.